Yeah, so today I want to talk about muscle relaxants in anaesthesia. So, muscle relaxants or neuromuscular blocking agents are a commonly used drug in anaesthesia, and along with hypnotic agents and analgesics, they form part of the triad of anaesthesia, or the so-called triad of anaesthesia. So, the aims of this post are to outline why muscle relaxants are used in anaesthetics, so what are their clinical indications, how do they work physiologically, so what are their mechanisms of action, and finally, I want to discuss how we would reverse their action if a patient was paralyzed, for example. So, why are muscle relaxants used? So, firstly, in intubation, so endotracheal intubation specifically, muscle relaxants help the vocal folds to relax. So, if you weren't to use a muscle relaxant and you pass an endotracheal tube through the vocal folds, it can stimulate them and cause something called laryngospasm, which can then cause those vocal folds to close shut, occluding the airway, which is obviously a really undesirable outcome in a surgical procedure. They also necessitate a lighter anaesthetic need. So if you give muscle relaxants alongside a hypnotic agent, you don't need to give as much hypnotic agent, which can result in better post-surgical outcomes, so better recovery, those sorts of things. Muscle relaxants are also used in surgeries, specific types of surgery, so things like ear, nose, and throat surgery, and some laparoscopic surgeries, because the muscle relaxants can relax the diaphragm, which can give the surgeons better abdominal access. So, secondly, I want to talk about how muscle relaxants work. So, I think the best way to demonstrate this is to look at this image in the middle. So, this is a neuromuscular junction. So, here we have the neuron, and here is the muscle. So in normal physiology, we have an action potential that spreads down through this neuron and causes these vesicles to release acetylcholine into the synaptic cleft. These acetylcholine molecules, these little blue molecules, bind with these green cholinergic receptors and cause depolarization of the muscle below. That's normal physiology. So how do neuromuscular blocking agents work in this neuromuscular junction? So what's their mechanism of action? So firstly, we have depolarizing neuromuscular blockers, and we also have non-depolarizing neuromuscular blockers. So depolarizing neuromuscular blockers, so things like suxamethonium, is chemically two acetylcholine molecules that bind with these receptors and cause rapid depolarization of this muscle below, which is then followed by a refractory period of a few minutes in which the muscle is relaxed. So this is a really good opportunity to do things like rapid sequence intubation, where you need the drug to act quickly, but it doesn't matter if it wears off quite quickly as well. So you don't need the muscle relaxation for the rest of the surgery, for instance. Secondly, there are non-depolarizing neuromuscular blockers. So these do not cause depolarization of this muscle, but these drugs do bind with the cholinergic receptors competitively and prevent acetylcholine from binding with them and causing the depolarization of this muscle. They tend to take a bit longer to act, but they also last a lot longer as well. So it's things like atracurium and rocuronium. So finally, I wanted to discuss how neuromuscular blockers are reversed. So this is just focusing on non-depolarizing neuromuscular blockers. Depolarizing neuromuscular blockers wear off spontaneously, and there isn't any reversal agents for them. So there are anticholinesterases. So in normal physiology, acetylcholine esterase enzymes sit in the synaptic cleft, bind with acetylcholine molecule, like free acetylcholine molecules, and remove them from the synaptic cleft. So anticholinesterases, things like neostigmine and pyridostigmine, bind with those enzymes and prevent them from removing that free acetylcholine. So there's more available acetylcholine in the synaptic cleft to then outcompete these non-depolarizing neuromuscular blockers, so they wear off more quickly. And secondly, the Sagamedex, these form a guest-host complex with rocuronium and similar drugs and remove them from the synaptic cleft, so there's less of that drug available. So to conclude, this post outlined why and how neuromuscular blocking agents are used, how they're reversed, and I think it provided a good introduction to neuromuscular blocking agents for medical students.